Hello and thank you for joining Webinar Campus. This is a special edition. This is the first edition of Grand Rounds where we get to discuss a case with input from anesthesia consultant as well as a related specialty consultant. This is an opportunity to discuss a multidisciplinary approach. Ultimately, patient care is a team effort. Today, I am happy to invite Dr. Lakshmi CP, Senior Consultant Medical Gastroenterologist, into our program, Grand Rounds. Dr. Lakshmi has been extraordinary throughout her academic career and continues to take interest in teaching activities. She has been my batchmate during my MBBS time in Government Medical College, Trivandrum. Welcome, Dr. Lakshmi. Dr. Rajesh is a senior consultant anesthesiologist at Baby Memorial Hospital, Calicut. Today, we are getting an opportunity to share his experience with anesthesia for surgical gastroenterology. Welcome, Dr. Rajesh. And Dr. Maria Jacob is a resident in anesthesiology at Baby Memorial Hospital. And she will be the presenter in the Grand Rounds today. Welcome to one and all. Let's start the proceedings. There will be an audience poll in between. There will be different audience poll questions in between for the participants to attempt, and do take this opportunity to raise your voice. And you are always welcome to put in your queries or comments in the chat box. We will address all those queries in the question and answer session at the end of the Grand Rounds. So please watch out for the audience questions. Now it's over to Dr. Maria Jacob to start the case presentation.
Thank you, sir. Shall I start?
Yes, please.
Good evening, everyone. Going to our case. Our patient is a 73-year-old male hailing from Mangawa who is a retired cashier. He presents with yellowish discoloration of urine and eyes since 3 weeks, loss of weight since 6 months, and loss of appetite since 6 months. History of present illness. The patient was apparently normal since 6 months ago. Since 6 months, he has been noticing a loss of weight of around 6 kg in the last 6 months and associated with malaise and loss of appetite. There was no associated fever, abdominal pain, no recent onset or worsening of diabetes, no associated waxing or waning of jaundice, no history of abdominal distension, there is no history of altered mentation or deranged sleep habits, no history of nausea or coffee ground vomitus, and no history of melena. Coming to the past history, he has been on treatment for diabetes mellitus and hypertension since the last 5 years, for which he is being on the drugs tab metoprolol 25 mg once daily, tab aldactone 25 mg once daily, tab metformin 500 mg twice daily, along with tab atorvastatin 40 mg HS from a primary health physician. He reports to have an effort tolerance of 2 flights of stairs. He claims that he can walk on the level ground for 1 hour without discomfort. Also, he has been on aspirin 75 mg once daily, but it was stopped 1 month ago. Coming to the summary of the history, here we have a 73-year-old male who is on treatment for type 2 diabetes mellitus and hypertension and has moderate effort tolerance, presenting with history of weight loss and loss of appetite for 6 months and painless progressive jaundice since 3 weeks, and was referred for further evaluation and management.
Okay, Dr. Maria, can we go to the next slide?
Yes, sir.
Okay, here's the first audience poll question. So I request everybody to put in their option. This is a true false question. Patients with chronic pancreatitis have similar risk of developing pancreatic cancer compared to general population. Option A is true. Option B is false. You have the poll window in front of you. Yes, I think it's a straightforward statement, and in another 10 seconds we can close the poll, I think. Yeah, if some more people are voting, we'll get 100% participation in the poll. Okay, fine. I'm stopping the poll. Okay. So 62% think it is false, and 38% says it is true. Okay, so this is the thing. The patients with chronic pancreatitis often develop diabetes or pancreatic exocrine insufficiency and are 10 to 20 times more likely to develop pancreatic cancer than the general population. So the statement was false. Okay. Dr. Maria, I think one more question is there. Yeah, this is the second question. 80% of pancreatic adenocarcinoma is detectable at an early stage as it produces early symptoms. Option A, true. Option B, false. Yeah, the poll window is in front of you. Yeah, I think there is a good consensus. Yes, fine. We'll be closing the poll in another 5 seconds. Yeah, thanks for the quick response. So 66% believes it's a false statement. 80% of the adenocarcinoma is detectable at an early stage. No, it's a very incipient malignancy. You should be really lucky to find out, get to the diagnosis at the early stages. So pancreatic cancer is known to often produce red flag symptoms once the disease has advanced beyond curative intervention. Only 10 to 20 patients will therefore have resectable cancer at the presentation. So this is the background on which we'll be discussing this case of painless progressive jaundice. I think we can proceed. Yeah. Okay. Dr. Rajesh, you can continue. You are muted, Dr. Rajesh.
Unmute, sir.
Your mic is not.
Is it okay? I'm audible?
Yeah, yeah.
Am I audible?
Now you are
Yes, sir.
audible.
Yes, sir. Yes, sir.
Yeah, Dr. Maria started very well, and she has, for the benefit of audience, can you elaborate on what you mean by effort tolerance? What you when you say that patient can climb up to 2 flights of stairs, what do you mean by that effort tolerance? Because that's very important for anesthesiologists. And is there anything negative in the history? And you said there is a significant weight loss. Is it significant? What's the how much weight he has lost?
Sir, to answer the first question, effort tolerance is the physiological concept of cardiorespiratory fitness, basically. That is, it corresponds to the metabolic equivalent. One metabolic equivalent is the oxygen consumption of an adult male of around 70 kg and 40 years at rest. It comes to around 3.5 ml per kg per minute. It corresponds to the maximal oxygen consumption. So when a patient says that he can climb up 1 flight of stairs, or he can walk 1 to 2 blocks on level ground, it means that his metabolic equivalent is between 5 and 9, which corresponds to moderate effort tolerance. And if he can climb 1 flight of stairs, it means that his VO2 max, or his maximal oxygen consumption, is above 10 ml per kg per minute, which corresponds to moderate effort tolerance. Now coming to the weight loss, he has lost around 6 kg in the last 6 months, is what he said. So,
in last 6 months, is it significant?
yes, and he is 51 kilograms. So it is more than, it's around 10% of his total body weight. So if you lose 5% of the body weight in 1 month or 10% in 6 months, the body weight, the loss of body weight is considered to be significant, and it can alert us to a chronic condition like a malignancy, tuberculosis, or any malabsorption syndromes like Crohn's. So it is in favor of a diagnosis of malignancy. That weight loss is 6 kg is significant.
Was it painless jaundice?
Sir, the jaundice was not associated with pain or fever. So, when a patient gives a history of jaundice, first we should be ruling out fever and abdominal pain because a triad of fever, abdominal pain, and jaundice is a Charcot's triad. It signals a cholangitis, which will alter our line of management. This patient did not complain of any pain, and also the jaundice was progressive over the last 6 months, sir.
Okay.
And Dr. Lakshmi, would you like to comment on the history presenting complaints? What Dr.
Painless progressive jaundice in an elderly patient is almost always a very bad sign as far as we are concerned. Almost always it is due to a malignancy. And in this patient, we don't have, from the history, we don't have a history suggestive of chronic pancreatitis. So we will have to see by imaging. Many a times patient with chronic pancreatitis may have a history of repeated episodes of pain, or they may have a history of steatorrhea. So those things are not there. So this looks like some pancreatobiliary malignancy, that's what we can say, by the presence of painless progressive jaundice. Or we don't have any other clues from the history. I think we'll have to go into physical examination.
I think it's very typical of the pancreatic malignancy that the classic findings will be very rare. Most of the findings will be more of generalized things like malaise. So there won't be any specific point in the early stage.
Pinpointing signs, sometimes you might get some features on physical examination, but usually, other than the fact that this is probably a pancreatobiliary malignancy, the location of the lesion and those things, we might get some clues on physical examination, but along with history alone, unless you have a definite history of chronic pancreatitis in the past, we won't be reaching much. And in one more thing, in the history of alcohol use and smoking is very, very important in these patients. From basically because chronic pancreatitis is more common in alcoholics. Pancreatic malignancy is also much more common in alcoholics as well as in smokers. So we have to take that history very carefully. And even from the surgical point of view, patients with alcohol abuse and malignancy, they don't do that well post-operatively because they are usually nutritionally very poor. And for the nutritional status also, I think she will come to it in physical examination, right?
Yeah.
Yes, ma'am.
So shall we proceed to physical examination?
I think
yes.
Proceed to physical examination. Yeah.
Physical examination. The patient was examined in the sitting up position. He is well built, but poor to moderately nourished. He has a height of 165 centimeters and a weight of 51 kilograms. And on calculation, the body mass index corresponds to 18.75. He is afebrile. His pulse rate is 88 per minute, which is regular, normal volume and character. No thickening of the vessel wall was noted. There was no radio or radiofemoral delay. All the peripheral pulses were present bilaterally. His blood pressure was 130 over 80 millimeters of mercury in the right upper limb. Respiratory rate was 16 per minute. It was regular, and this pattern was abdominothoracic. There was no pallor, but icterus was present. There was no clubbing, no lymphadenopathy, no significant lymphadenopathy, no edema, no cyanosis. That's it about the general examination. Proceeding to the examination of the airway. External appearance, there was no visible swelling, deformity, or any active bleeding. Both the nasal cavities were patent, and mouth opening was around 6 centimeters. Teeth, gums, and palate were found to be normal. Modified Mallampati grade was grade 3, and his lower jaw could be protruded about the ahead of the upper incisors. Temporomandibular joint movements were normal. On checking the thyromental distance, it was found to be around 6 centimeters. Sternomental distance was 12 centimeters. There were no masses or scars, and neck extension and the neck flexion and extension were found to be normal. Proceeding to examination of the gastrointestinal system, oral cavity, the patient has good oral hygiene. Lips, teeth, gums, palate, gingiva were normal. Buccal mucosa showed the evidence of icterus. On inspection, abdomen was scaphoid. There were no dilated veins or visible pulsations. Umbilicus was central, and all the quadrants were moving equally with respiration. And hernial sites were found to be normal. On palpation, the liver was just palpable below the right costal margin in the midclavicular line. There was gallbladder could not be palpated. Hernial orifices were normal. Percussion was not done. Auscultation showed normal ball sounds. Regarding other systems, the cardiovascular system and respiratory system examination were within normal limits. First and second heart sounds were heard, and air entry was bilaterally equal with no added sounds. Regarding the examination of the nervous system, higher mental functions were found to be normal. There was no altered mentation. He was conscious and oriented. Sensory and motor system examination was within normal limits. There were no abnormal movements, no tremor. And the examination of the skull and spine was also found to be normal. There was no deformity. That's it about the examination part.
Okay, Dr. Rajesh, would you like to elaborate anything on the physical examination?
No. Do you get any positive findings other than John?
Sir, he is on the.
Hello?
Your voice is breaking, sir. Sir, his body mass index is 18 points.
I think there is internet connection problem with Dr. Rajesh. Dr. Lakshmi, you would like to comment on
this from the history, what we are getting is that the patient is already malnourished. So that again, definitely from the history point of view, it points out to probably a malignancy or a tubercular etiology. So malnourishment is there, and then obviously from the history itself, he is jaundiced. What is there in examination is mostly some negative features, like he doesn't have an enlarged, very big supraclavicular or cervical nodes, or he doesn't have ascites and all those, which would point out to an unresectable or an advanced malignancy. So all we can say is that he doesn't have features of an advanced or unresectable lesion on our physical examination. The gallbladder in this case is not palpable. So if you have a well-defined, palpable and visible gallbladder, then it points out to a lower biliary obstruction, usually of a malignant etiology. But even though it is said in clinical examination, this finding is not there in many patients. So we only have some negative features. We can say that this doesn't look like an advanced malignancy. That's all we can say on the physical examination. I think we will have to rely on a lot of investigations also to go ahead with the findings.
Yes, ma'am.
Okay. Fine. Generally, after case presentation, we would like to have, from anesthetist point of view, what all investigations you would like to have in this patient coming for a possible surgery. So once we get the investigation reports, we'll find out which surgery he or she may be coming for. But as an anesthesiology, what investigations would you like to have?
Sir, I would like the patient to get a complete blood count to look for anemia and presence of infection, and his platelet counts I would like to know. And his peripheral smear, I want to rule out hemolysis, since it's the case of jaundice, or any diseases like conditions like hereditary spherocytosis. I would like to have his random blood sugar, or ideally fasting blood sugar. and HbA1c status for the control of, to know the long-term control of blood sugars, renal function tests, serum creatinine and serum urea to look for any baseline renal dysfunction or any hepatorenal disease, and serum electrolytes, since the patient is already on a diuretic and also the patient is jaundiced. So I would like to have a baseline serum electrolytes, and a liver function test as an evaluation of jaundice to differentiate the type of jaundice. If it is a pre-hepatic, hepatic, or obstructive type of jaundice, we would like to have a liver function test, and PT-INR and also the synthetic function of the liver examined by the serum albumin and PT-INR coagulation profile. And proceeding further, I would like to get an electrocardiogram, because this patient is a 73-year-old male who is a diabetic and hypertensive since 5 years. So he's there is increased chance of atherosclerotic disease, and also diabetic macrovascular involvement is high. So even though the patient gives a moderate effort tolerance, I would like to have a baseline electrocardiogram evaluation, 12-lead electrocardiogram. And I would also prefer a two-dimensional echocardiography. That is, in case if I find any STT wave changes or any changes suggestive of ischemic heart disease in the ECG, or if the patient has a new onset symptoms of ischemic heart disease. Otherwise, also in a 73-year-old patient going to undergo a major upper abdominal surgery, 2D echo would give a good idea of the static function of the heart. Then I would like to have a chest X-ray and pulmonary function test, not indicated in all patients, but in this patient the points in favor are he is a geriatric patient, and also he is to undergo an invasive upper abdominal surgery. And also pulmonary function test will also give an introductory training to the patient on performing pulmonary rehabilitation measures like incentive spirometry. And we would also have a baseline pulmonary function test as procedures which the patient might be subjected to. The invasive surgeries usually result in post-op pulmonary complications. And also if we are planning on invasive lines, patient is also at the risk of pneumothorax. So I would like to rule out, especially in a smoker. This patient was a non-smoker. Especially in a smoker, I would like to rule out the presence of any apical bullae. A panendoscopy and CT scan of the abdomen and pelvis for the purpose of resectability as suggested and for the evaluation by the gastroenterologist and the gastrosurgeon. And blood grouping, as I am expecting a surgery with massive fluid shifts. Viral markers as part of protocol, and also in this case to rule out chronic viral hepatitis, and COVID RT-PCR test, which is a protocol in our hospitals now.
Okay, fine. Dr. Rajesh, your inputs on the proposed investigations? I think there is still
net connection
activity issue. Dr. Lakshmi, on the proposed.
Yeah, from the
Dr. Rajesh, yeah, your audio is not clear. Dr. Lakshmi, please continue.
Yeah, from a gastroenterologist perspective, we would like to definitely see the liver function test, see how deep is the jaundice. We confirm that it's a obstructive kind of obstructive jaundice on liver function testing also. And obviously, usually the first step we go in for an ultrasound abdomen. The ultrasound is the first investigation whereby you see whether it is an obstructive jaundice or is it a hepatocellular jaundice. So if it is an obstructive jaundice seen on ultrasound, then definitely we go in for a better imaging like a CT or an MRI, and then we decide upon the findings and then decide whether we need to go for endoscopic ultrasound, ERCP, and other such investigations. So baseline from my side, liver function test, and then a good quality ultrasound.
Okay, ma'am. Shall I proceed?
One second.
Sorry, anything Am I audible now?
No, still voice is breaking. Hello? Hello?
Hello?
Okay.
Yes,
Hello?
sir.
Now? Am I
No,
am I audible?
still your
Better.
voice is breaking, but it's better.
Yeah. Okay, we'll continue.
Yeah. Now it seems clear. Yes.
Dr. Maria, can you elaborate more on how will you do the incentive spirometry and all? That's very important for us.
Sir, regarding incentive spirometry, it is maximal inspiration. So patient is asked to sit erect, and he or she is asked to exhale normally, and then purse his lips tightly around the mouthpiece of the spirometer, and then inhale maximally and hold it for 5 seconds. And this maneuver has to be performed at least, recommended is at least 10 times in 1 to 2 hours, or 15 times in 4 hours is the recommended pattern of performing incentive spirometry. Ideally, it has to be started 48 to 72 hours prior to the surgery and has to be continued post-operatively for prevention of atelectasis, improve the respiratory muscle performance and transpulmonary pressures, and maintain the airway patency. These are our goals in performing an incentive spirometry, in educating the patient about incentive spirometry.
And I think the patient will also have some feeling of well-being that he or she is also actively involved in the post-operative management
process.
So that's why it's called incentive spirometry. They are given specific targets and they are trying to chase the target positively, not out of compulsion, because they know it even prior to that stress or surgery.
That's very good.
So there is also flow directed and volume directed. There is that the normal one what we see is a tri-ball. It is mainly dependent on the flow. It gives more feedback to the patient. The balls which is arising. We have another type which is also the volume based. That is, there will be one spirometer with volume levels marked.
Suppose the patient cannot be mobilized for a routine pulmonary function test. So what will you do? Can you go for a bedside test?
Yes, sir. We can do a bedside pulmonary function test. For example, a Sablace's breath holding test or a breath holding time in that patient. If you can hold breath for more than 25 seconds, it corresponds to a vital capacity of more than 3.5 liters or higher. If it is less than 15 seconds, it means that cardiopulmonary reserve is very poor and it is actually a contraindication for elective surgery. High risk of post-operative pulmonary complications.
Very good. Okay.
Okay, we'll proceed to the set of investigations for this patient. Yes.
So on investigation, this patient had a hemoglobin of 12 gram per deciliter. His total counts were 8,500 per millimeter cube, and differential count neutrophil 79, lymphocyte 19, and monocyte 2. Platelet count 2.56 lakhs per millimeter cube. Peripheral smear was normal. Random blood sugar was found to be 163 milligram per deciliter, and HbA1c 6.5%. Regarding the renal function, serum creatinine was found to be 0.6 milligram per deciliter and urea was 14. And potassium was 134 and 4 milliequivalents per liter respectively. Coming to the liver function test, serum bilirubin was found to be a high value of 18.6, of which 13.3 was direct bilirubin. SGOT was 80 units per ml and per liter, and SGPT was 92, and alkaline phosphatase 586. Albumin was 3 gram per deciliter, and regarding PT-INR, a test value was 10.8 and INR was 1.09. His blood group was checked, was O positive, viral markers and COVID antibody tests were negative. and his CA99 marker was found to be raised 136 units, and on urine analysis, bilirubinuria was detected. This was his electrocardiogram. This shows pathological Q waves in lead 3 and lead AVF with the presence of ventricular premature contractions. Chest X-ray was found to be normal, no mass lesions, no cardiomegaly. On echocardiographic evaluation, he was found to have mild LV systolic dysfunction with an ejection fraction of 45% and left ventricular diastolic dysfunction.
Okay, there is an opportunity for the residents watching this webinar to attempt. This is a question for you. Pre-operative NT-proBNP, a useful screening test to identify patients at risk of developing functional heart failure. Option A, true. Option B, false. Okay. Yeah, here is the poll window for you. So pre-operative NT-proBNP as a screening test to identify patients at risk of developing functional heart failure. I think the recent Canadian Society guidelines, they have specifically incorporated this value into the pre-operative decision-making algorithm. So 70% almost is voted. The poll will end in another 5 seconds. Yes. Okay, so this is the result. 79% believes it's true, and I agree with that majority. Raised NT-proBNP levels are associated with significant increased risk of cardiovascular complications and cardiac deaths after non-cardiac surgery. So you do a stratification based on the pre-operative NT-proBNP, and if indicated, you definitely follow it up with the NT-proBNP values in the post-operative day 1, day 2, and definitely look out for any features of ischemic heart disease in the perioperative period, and there should be a high index of suspicion, and you should have 12-lead ECG to support your diagnosis. Okay, that is part of the new strategies for detecting and probably avoiding perioperative myocardial injury and failure. You can continue, Dr. Maria.
Yes, sir. Going to the imaging, a CT scan of the abdomen and pelvis was done, and both showed bulky head and uncinate process of pancreas with calcification in the head region and hypodense area in the uncinate process. Dilated main pancreatic duct and common bile duct with mild bilobar intrahepatic biliary radical dilatation due to compression by the calcification in the pancreatic head. It is suggestive of a mass forming chronic pancreatitis. Suggested tumor marker or ERCP to rule out remote possibility of an underlying neoplasm. Prostatomegaly was also the positive finding. The patient underwent endoscopic examination. An endoscopy was performed, and the findings were this, that D1 segment was deformed. The endoscope was negotiated with difficulty. Ampulla was found to be normal. Endoscopic ultrasound study showed 3.3 into 3 centimeter hypoechoic mass lesion involving the head and uncinate process, multiple large intraductal calculi in the head and uncinate process. Common bile duct was dilated 15 millimeters up to the mass. Pancreatic duct in the head, tail, and the body was dilated to around 5 millimeters. Portal vein, portal confluence, superior-mesenteric vein, and splenic vessels were normal. Celiac artery was normal. Superior-mesenteric artery normal. Multiple small periportal and peripancreatic nodes were found. There was no ascites. In liver, there was minimal intrahepatic biliary radical dilatation, no space occupying lesion. The impression of endoscopic ultrasound was chronic calcific pancreatitis with mass lesion in the head of pancreas with biliary obstruction, and it is found to be operable by the endoscopic ultrasound criteria.
Okay, shall I go straight away to Dr. Lakshmi for an point of view from medical gastroenterology, all these investigation reports?
Yes, so our investigation reports basically the endoscopic ultrasound, which shows that there is a mass lesion in the head of pancreas. It was not that well visible on CT, but the EUS typically shows this mass lesion. Now, whether to biopsy it or not is always a million-dollar question. You know, a negative biopsy, a negative EUS biopsy doesn't rule out a malignancy, and there are always the risk and complications of an EUS guided by FNA and biopsy also. So for a Whipple surgery, preoperative tissue diagnosis is not a must. This is one of the conditions where we go in for a very major surgical resection without a preoperative tissue diagnosis. Now, the questions in this patient, as far as a gastroenterologist is concerned, is that his jaundice is relatively on the higher side. He's having a bilirubin of around 18, but there is no history of any cholangitis. The counts, everything doesn't favor any cholangitis. So he is not a primarily, it's not a primarily infected biliary system as far as we can understand. So to reduce his jaundice, there is always an option of stenting this patient. That is, if you do an ERCP and put a stent in this patient, the jaundice will come down, the nutrition will improve, and in the waiting time, if you want to stabilize his diabetes or something, that is always a good option. But stent has its own complications, and it can lead to emergence of a polymicrobial infection in the post-operative period. It can lead to all sorts of ERCP-related complications. So this is something which we decide on a case-to-case basis. Obviously, anesthetist point of view, I think you would like to have a non-jaundice patient who's nutritionally better. This patient of ours has got a bilirubin of 18 and an albumin of 3. I don't think you would much, you know, you would prefer a patient with an albumin of 4 and a bilirubin of 2, I think, from an anesthetist point of view. But from a surgeon's point of view, a stented patient increases his intraoperative difficulties. The technical difficulties are more. Post-operative infection risk is also high. So it's usually an individualized decision. If there is any cholangitis, any history of infections, the suspicion of cholangitis, then definitely we do a stent. And stenting also involves another GA as far as we are concerned. You know, patient will need a general anesthesia or a good propofol sedation for ERCP procedure done outside the operating room in a patient who is not such a good risk. So it has got its own risk. So in this patient, I think because there is no cholangitis, I think it will be better that we go in directly for a surgery. And preoperative biopsy is not there, so we will have to explain to the patient the risk of negative Whipples. After surgery, there is always a small risk that the biopsy may not show malignancy, but that risk has to be taken, because to go in for a tissue diagnosis, you have to go in for more invasive things, and that itself can lead to complications. So it's an informed decision.
Especially we can stress on the factor that the projected survival rate is very less if it actually proves to be a malignant lesion.
Yeah. We have to explain the entire surgical risk. This is one of the major GI surgical procedures that's done. So we have to explain the surgical risk, the risk of complications, the risk of leaks, the risk of bleed, and mortality risk of Whipple. Along with that, the possibility that we are going in for a surgery without a preoperative tissue diagnosis. That has to be emphasized to the patient, because many a time there has been litigation issues when the Whipples becomes negative. That happens once in a while. Even in the highest volume centers, up to 5 to 10% of Whipples can be a negative Whipple. That is Whipple done for a non-malignant lesion. So we have to explain that also to the patient. We are taking this patient up, elderly, high-risk patient, patient with cardiac risk. We are taking the patient for a Whipples without a tissue diagnosis. But that is what is done in almost all centers throughout the world. It's acceptable as far as all our guidelines go.
How about the option of having a frozen section before proceeding to a radical surgery?
Frozen section option is always there, especially in centers with the facility for frozen section. It's not always available in every center. And the only question is, chronic pancreatitis is a mass forming kind of a disease. This patient has got chronic pancreatitis. he has got a fixed fibrous pancreas, and it's a fairly 3 centimeter lesion, and even a negative frozen section doesn't actually rule out the possibility of malignancy. Only when you get a full Whipple specimen, you might sometimes get the positive diagnosis. So frozen section helps in selected patients, especially if there is a doubtful resectability. Intraoperative, the surgeon sees that the vessels are getting infiltrated. There is going to be a portal vein resection also. Sometimes people goes into a portal vein resection. So if you're going to that kind of a borderline resectable cases when found intraoperatively, then there is a role of frozen section, but not in every case.
Dr. Rajesh, you would like to put in some points?
Yeah, Dr. Lakshmi has mentioned about pre-op stenting in selected cases, and once we stent, we had to wait for at least 2 weeks. No, at least
After
minimum 2
stenting,
weeks.
minimum 2 weeks, but 4 to 6 weeks has also been recommended. Now, stenting, one more thing I would like to emphasize, there are certain centers where the waiting time for surgery is long. So especially I would say like centers like RCC Trivandrum, where the waiting list for a surgery is on the higher side. So those kind of centers, they usually go in for a stenting, because by the time the patient waits for the surgery for 3 to 4 weeks, the bilirubin levels would go up very, very high, and the nutrition will be very, very poor. So if the waiting time for surgery is high also, then we go in for ERCP stenting.
So it's always has to be individualized.
Yes, it is individualized and center based also. There are so many local factors in the center which decide whether to go in for ERCP or not.
Thank you.
Okay, and Dr. Maria, we'll move to the next part. Yeah.
Yes, sir.
Yeah, next part. So next portion is about perioperative clinical predictors. I think there are a good number of indicators or risk scoring strategies. So there are some patient-related factors, some surgery-related factors, and some preoperative testing-related factors. So there are a good number of factors enlisted in the table, like patient-related congestive heart failure, ASA score more than 2, age above 65, or patient falls into this category. Chronic obstructive pulmonary disease like that, functional dependence, altered sensorium, history of smoking, respiratory infection. Of course, surgery related factors, it's abdominal surgery, surgical duration more than 3 hours, requirement of GA, transfusions, prolonged hospitalization, all are perioperative clinical predictors. Going to the numbers, serum albumin less than 2.5 gram per deciliter, anemia, HB less than 10 gram percent, low room air saturation, chest X-ray findings. These things will point to a high risk category. I think there are some other risk predictors, especially when we are about to discuss with the patient regarding informed consent. Dr. Maria, you can go ahead with the other clinical scores. Before that, one more question. I think this is a little too early to discuss, but I would like to get audience input on this. It's a simple thing. Again, pre-operative oral supplement and enteral nutrition is a valid strategy in malnourished patients prior to pancreatic resection. We are speaking about optimization. The issue is whether this statement is true or false. Pre-operative oral supplement and enteral nutrition is a valid strategy in malnourished patients prior to pancreatic resection. Okay. So, shall I stop the poll? Yeah, I'll wait for 5 more seconds. Yeah, I think, yeah, fair enough. So 76% agree with this statement, and I also agree with that. It is a correct statement. The malnutrition universal screening tool must for adults can prompt implementation of effective nutritional interventions, and malnourished patients should be optimized with oral supplements or enteral nutrition pre-operatively. That is a good strategy.
Shall I
Yeah.
proceed?
Yes, please.
Coming to the surgical risk, different risk criteria for this patient. First, we are going to the surgical risk. It is the surgical risk estimate according to the type of surgery alone. Now, what risk? It is the risk for 30-day cardiac death or cardiac mortality or cardiac events. What you should note is in that there are no patient factors in it. It is solely based on what type of surgery the patient is undergoing. It used to be classified into low risk, intermediate risk, and high risk. Low risk means the risk of 30-day mortality and cardiac events is less than 1%. There are surgeries like superficial surgeries, breast surgeries, endocrine thyroid surgery, or any eye surgery, and gynecology and orthopedic minor surgeries, and even asymptomatic carotid surgeries. Intermediate risk means 1 to 5% risk. It included major orthopedic gynecological surgeries and intraperitoneal surgeries like splenectomy and cholecystectomy, and also head and neck surgery, everything, and even renal transplant comes under intermediate risk. And high risk means the risk of cardiac events is more than 5%. That includes pancreaticoduodenectomy and adrenal resection and lung transplantation, etc. But recently they have made it into just low risk and elevated risk. In that, the elevated risk, pancreatic resection comes under an elevated risk surgery. Coming to the revised cardiac risk index. Now, this incorporates the cardiac risk of a patient undergoing a non-cardiac surgery. There are patient-specific factors also incorporated in this RCRI score or Lee's index. So, in this, the criteria are high-risk surgery, that is intraperitoneal, intrathoracic, or suprainguinal vascular surgery, history of ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, pre-operative treatment with insulin, and pre-operative creatinine of more than 2 milligrams per deciliter. In this patient, like all other patients, after admission, the glycemic control was using insulin. So the fifth point was also a +1 for this patient. On that account, he is undergoing a high-risk surgery. He is a diagnosed ischemic heart disease, even though it was a silent myocardial infarction since the patient is a diabetes. And also he has undergone preoperative treatment of insulin. So if the score is 3, then the risk is 5.4% risk of major cardiac events. So the risk is like this: if there is 1 point, it corresponds to 0.4%. 2 points, it is 2.4, then 5.4%, like that. That is regarding the Lee's index. Now coming to a surgical risk calculator. This is a National Surgeons Quality Improvement Program surgical risk calculator. It is developed by the American College of Surgeons. So in this, we actually enter the type of surgery, and also there are 21 variables, patient factors like the age group, the sex, functional status, if the surgery is an emergency surgery or not, the ASA class, history of steroid use or ascites, sepsis, ventilator dependency, if he has disseminated cancer, presence of diabetes, hypertension, congestive heart failure, dyspnea, recent smoking, history of severe COPD, dialysis, acute renal failure, and BMI. And these are the factors involved in the above are the factors we enter in the evaluation of NSQIP risk score. Recently, that's from 2019, there is a facility of calculating geriatric risk outcomes separately. Like in a geriatric patients, there are additional risk involved. Post-operative outcomes, there are like cognitive impairments and decreased mobility are higher in geriatric population. For them, we enter the parameters like mobility aids, origin status, that if the patient is supported at home or not, if he has a history of any fall, if he is having dementia or cognitive impairment, if there is history of palliative care, and if he himself signed the consent or a surrogate of the patient signed. So when you enter these values in this risk calculator, so we get the results like this. So in this, if you analyze The colored area represents the patient's risk on a scale of 100, and the black mark represents the risk of an average patient. So this helps us to explain to the patient that what is his or her risk in comparison to the general population and an average population. So the the hospitals enrolled in this program, so this is a large database. So so a patient can get an estimate of his risk in the compared to the empirical risk in the general population. Disadvantage is that this is by the American College of Surgeons, it has not been extrapolated to other populations. There is one drawback. So in this, you can note that among the serious complications and pneumonia, the patient's risk is either below or just approaching the that of an average person's risk. Whereas consider cardiac complications and also the discharge to a rehab facility. That means the need of the patient being discharged to any place other than the home, like a care center or a more specialized care center, that is higher than this patient has cardiac risk and discharge to a rehab facility higher than that of a normal patient, of an average patient, not normal, average patient. And regarding geriatric outcomes, he has very low, comparatively lower risk of developing postoperative delirium, functional decline, and also new mobility aid use. But he has a risk approaching or more than that of an average patient for developing a new pressure ulcer or worsening ulcer. And also it calculates the approximate predicted length of hospital stay is estimated to be 10 days. So NSQIP risk calculator gives us a very patient specific and procedure specific risk of the patient in comparison to the empirical risk. So that is the advantage of this risk calculator.
I think the number of
surgery
factors
risk and patient's risk
we need to enter are more, but in this era where internet is freely accessible and most of the doctors and the patient relatives will have internet access, so we can easily discuss the perioperative risk or what to expect in the perioperative period very easily using this indicator. And you can be more specific. You can give this much risk of cardiac complications, like that. Even the geriatric concerns are explained. The risk of extended ICU stay, everything comes in NSQIP. Dr. Rajesh, you want to give any inputs in this risk stratification?
So it is based on an ideal scenario where we follow the actual protocols and evidence-based medicine, but how much we can extrapolate to our context, we don't know. But it is it's really available in the Google, and actually show it to the patient that this is a risk of undergoing surgery because it includes risk in patient. Okay.
Okay, and I think one more thing is the surgeon can give his input, like still we can go up on the risk one step ahead. Surgeon has the leverage, but of course most of the centers, surgeon will be getting the consent first and then sending the patient to the pre-anesthesia clinic. So that part is still there, that option is still there with the NSQIP. Dr. Lakshmi, you want to put in, because informed consent, we need to educate the patient regarding what to expect in the intra-op and post-operative period.
Yes, especially for a Whipple surgery, the consent is extremely important because, as we all know, it is a surgery with a significant mortality risk as well as risk of complications. Some of these complications can be very prolonged. For example, leaks and bleeds. They might need a prolonged hospital stay, prolonged therapy, and the patients and bystanders must be ready to accept, the risk of possibility of risk. So this is one surgery where you explain in detail every complication that can possibly happen, especially to avoid medical legal issues in future. So I think ideally the surgeon and anesthetist should be discussing this issue with the patient and bystanders in a single session. Practically, it doesn't happen in most hospitals, I think.
Okay. Okay, Dr.
The
Maria,
anesthetist should take a separate consent. That's very important. And if you are anticipating post-op ventilation, that also should be explained.
we need to be specific on our technique like thoracic epidural. We need to explain before the patient comes in for the surgery along with our anesthesia consent.
Including the need for central line and artery line insertion.
Yes, sir.
Okay, yeah, fine. We already consulted. Yeah, now Dr. Lakshmi, you can take us through the workup of a case of CA pancreas.
Now, from the gastroenterologist point of view, as we said, the basic lab test and CA19-9. If the CA19-9 is significantly elevated in a patient with no cholangitis or no recent pancreatitis, it is a very significant positive predictor that we are dealing with a malignancy. So in this patient, it's actually only a mild borderline increase in the CA19-9. And the most important investigation for our patient would be the endoscopic ultrasound, as seeing a mass lesion in the and a dilated duct, seeing a definite mass lesion. If needed, you can take a biopsy from the mass lesion, but the biopsy from the mass itself involves another anesthesia. US FNA usually almost always is done under anesthesia, and there is a risk of bleeding, there is a risk of pancreatitis with that US FNA. So we should explain the risk that for a tissue diagnosis, you may need investigation which can itself lead to complications. So if there is a doubt about the diagnosis, then only we go in for an FN. And as we discussed earlier, if you have a deep jaundice, or if you have a cholangitis, or if your waiting time for surgery is too long, then we need to go in for an ERCP. This is an image showing ERCP where you see the ampulla, you put in a stent and relieve the biliary obstruction. And at least 2 weeks after the ERCP, you take the patient up for surgery. So in our patient, we have gone in for an endoscopic ultrasound, which showed a fairly definite mass lesion. So with that in mind, explaining that we have not taken a preoperative tissue diagnosis, I think we should proceed with ERCP. Sorry, with the Whipple surgery. Now, as I said, a surgeon would obviously prefer a non-stented patient. From an anesthetist point of view, I have always seen that anesthetists would obviously prefer a non-jaundice patient. And next slide, please. So, preoperative ERCP, if it is done, you need a prone GA, usually given in the endoscopy room, outside the operating room. ERCP has got its own risk of bleeding, pancreatitis, the risk of the prone GA, as well as it can even lead to complications like a duodenal perforation and air embolism. So even though reducing jaundice before surgery looks like a good idea, it has its own complications, and post-operative infection rates are also high. So next slide, please. Almost always, it is not routinely recommended. Decision is individualized in most centers. If you have cholangitis, waiting time is more than 2 weeks, go in for ERCP. And suppose you are planning an EUS FNA in that patient, we should always try to do both the ERCP and EUS in the same general anesthesia. We have seen patients who go in for an EUS FNA first, then they go in for an ERCP. You know, introducing 2 sessions of GA, and then the patient goes in for a Whipple. I think that is something which we can definitely avoid. If you're planning ERCP, if you're planning EUS, FNA and biopsy, do both in a single GA sitting.
Okay, now for our energetic, sorry, yeah, Dr. Rajesh, you want to give some input?
And giving anesthesia, it's a ERCP is almost invariably it is an outside OT procedure, and that too in a remote location. So it also carries a major risk for anesthesiologist, and sometimes the supporting staff and a single anesthetic will be managing in the outside OT procedures. Unlike in the OT where you have assistants and you have help all the time, so that also has to be taken into consideration.
Okay, true. So that's the issue with anesthetizing for ERCP. I think that itself is a separate topic, anesthesia for gastroendoscopic procedures. So now an audience question for the energetic residents attending this webinar. Which of the following are predictors of poor outcome in liver dysfunction? Option A, child's class C. option B, malnutrition, option C, emergency surgery, option D, sepsis. Just to remind you, this is a multiple response question. More than one option may be clicked, and you have this poll window for you. I think that energy is getting induced into the brain, though we are discussing gastroenterology case. Good number of people are responding. Yes, another 5 seconds, I'll close the poll. Thank you very much for your input. Majority believes option A is correct, but good number, 60, and 68% believes option B, option C, D are correct. And I would say that all the options are correct. Child's class C, malnutrition, emergency surgery or surgery procedure on a septic patient, all are indicators of poor outcome in a scenario of liver dysfunction. Okay, so all the options are correct. Thank you for your response. We look forward to your cooperation in the next audience poll question. Dr. Maria, you can proceed. Yeah, you are muted. Dr. Maria, you have to unmute. Okay. So preoperative optimization strategy, I think we will first take inputs from Dr. Lakshmi from medical gastroenterology aspects.
From outside, nutritionally, these patients are usually poor. I'm not talking about our patient. If there's a chronic calcific pancreatitis, as we have in our patient, they usually have features of pancreatic exocrine insufficiency as well as endocrine insufficiency. Now, when you ask a history, you may not get a classic steatorrhea history, but the low albumin, sometimes a low hemoglobin. So all these factors might, even a low ferritin, so all these factors might point out to a pre-existing subtle pancreatic exocrine insufficiency, which is only going to worsen in post-operative phase. So post-operatively, after Whipple, the pancreatic exocrine insufficiency worsens. So you are expecting a very nutritionally bad patient, even pre-operatively and post-operatively. So if there is any waiting time for surgery, aggressive nutritional rehabilitation with a trained dietitian to be monitoring the patient frequently is a must. Now, the other question is, because of chronic pancreatitis, again, the patient usually has pancreatic diabetes, which is very, as we all know, it's a very brittle diabetes, very prone to major fluctuations in the sugar levels. So preoperative blood sugar optimization is also important and very difficult also in these patients. Unfortunately, our patient has got a good HbA1c. He seems to be a well-controlled diabetic. Now, anemia is one more thing which we need to look into. Many of these patients with chronic pancreatitis, they may have a nutritional anemia. As I said, because of exocrine insufficiency, malabsorption state, they may have a low anemia. And sometimes many of these pancreatic lesions infiltrate into the duodenum, or they may present as periambulary lesions. And that itself leads to chronic GI bleed. So anemia from nutrition as well as GI bleed, which may have to be corrected pre-operatively.
Coming to the other points, adding to what Dr. Lakshmi has said. So our main concern in this patient in a case of obstructive jaundice will be broadly coagulopathy, sepsis and renal failure. Coagulopathy because of the deranged absorption of the fat soluble vitamins and deranged gamma carboxylation of the clotting factors, and also the deranged synthetic function of the liver. We have hypoprothrombemia, so there is associated coagulopathy in this patient. So the patient might need, in case of elevated INR, patient might need preoperative vitamin K supplementation. And if we are, if APTT is prolonged and if we are planning on an epidural, patient might need a preoperative administration of fresh frozen plasma. And regarding sepsis, the patient, there is in obstructive jaundice, there is biliary stasis. In biliary stasis, always the patient is prone for infection, but usually, most probably, it is usually a monomicrobial infection, which calls for empirical antibiotics. or if the patient is undergoing a so endoscopic procedure like manipulation of the biliary system, then there will be obviously leakage, and then the infection, there are chances that patient has a polymicrobial infection. In that case, we need a wide spectrum coverage of antibiotics. Regarding the renal involvement, there is high chances of hepatorenal involvement. It is mainly due to the increased circulating bile salts and endotoxin release, which will cause, and also the decreased cardiac output, causing renal hypoperfusion and ischemic injury to the kidney. So we have to optimize the preoperative renal function of the patient. The baseline renal status has to be checked, and the most useful and most efficient strategy in optimizing the renal function is maintaining normovolemia. You have to prevent dehydration and avoid nephrotoxic drugs, NSAIDs, and prevent nephrotoxic drugs. And previously we used to advocate administration of IV mannitol, since it has decreases peritubular edema and has antioxidant action and also osmotic diuretic action. But recent evidence is shows that the patients who received mannitol and those who did not, there was no much difference in the outcome regarding the renal injury. So the ideal strategy as of now is to maintain normovolemia and maintain adequate renal perfusion. We have already seen the optimization of the glycemic status and nutrition status by Dr. Lakshmi. Regarding cardiac assessment and optimization, we already said that this patient is has high risk for ischemic heart disease, since the patient is a diabetic and hypertensive and hypercholesteremic. High risk for macrovascular disease is high. So 12-lead ECG and echocardiography was done, and we have found that there is a systolic diastolic dysfunction. So what we can do is, this patient is a patient with moderate hypertolerance. So he is not a decompensated patient. So what we can do is to prevent the worsening, whatever cardiac medications he is on, according to the ACC-AHA guidelines 2014, is beta blocker which he is taking has to be continued to the surgery, and the antihypertensive drugs have to be continued to the day of surgery. The only drug which needs holding of 24 to 24 hours prior to surgery is a angiotensin receptor blocker, which the patient is not taking. So all these drugs can be continued. Ecospirin also can be continued, but the patient had stopped taking it 1 month back. So that is regarding the cardiac assessment. And regarding the pulmonary assessment and optimization, if the patient, we have to at least perform a bedside PFT if we are not able to mobilize the patient to a PFT, to a routine PFT. And our strategy in pulmonary optimization is that first, if the patient is a smoker, cessation of smoking is the most important factor. Then you have to advise the patient on incentive spirometry. If the patient has infection, the infection has to be treated and secretions have to be drained with good chest physiotherapy. If in case of smoking cessation, you have to see that even a smoking cessation of 24 hours is effective, and for good decrease in mucociliary, increase in the mucociliary clearance and decrease in secretions, 6 weeks of cessation is advised. Regarding the deep venous thrombosis prophylaxis, ideally the patient requires DVT prophylaxis preoperatively itself. The most what is practiced mostly is Clexane, low molecular weight heparin, subcutaneously administered. Mechanical and pharmacological methods are there. Mechanical methods will be DVT stockings and compression stockings, and also sequential compression devices. And pharmacological will be the low molecular weight heparin.
And regarding correction of anemia, you can even start IV ferritin carboxymaltose if the ferritin level is very low, like less than 100 microgram per liter.
Yes, sir.
So what pre-medication you will give?
Sir, on the night before surgery, I would like to administer a proton pump inhibitor, for example, pantoprazole 40 mg orally. Since the proton pump inhibitor to be effective, ideally has to be administered 12 hours prior to the So I'd like to administer it on the night of surgery. Also, anxiolysis, I would like to administer lorazepam 1 mg tablet before he goes to bed. And on the morning of surgery at 6 a.m., I will advise him to take a clear fluid. A black coffee or black tea is an option. And after he comes to the preoperative holding bay, I will secure a good patent IV line. Then I will administer titrated doses 0.5 plus 0.5 of midazolam, intravenous midazolam, under my strict supervision, along with injection of dansetron 4 mg as an antiemetic before taking up the patient to OR.
Since the patient is diabetic, you won't be giving carbo load. Okay.
Yes.
So what about the monitors, pre-induction and post-induction?
So I'll shift the patient to the operating table. Prior to induction, I would like to see a baseline pulse oximeter, non-invasive blood pressure, and 5-lead ECG with ST analysis. After induction, I shall secure the my invasive lines, and by that time I shall have an in addition to the pre-induction monitors, I shall have an temperature monitor and ATCO2 monitor, capnography, and invasive. After I secure my invasive lines, I will have an intra-arterial blood pressure monitoring. I would prefer to have an invasive arterial monitoring because this is a invasive surgery. I'm expecting massive fluid shifts and also deranged massive fluid shifts and also deranged dyselectrolytemias I'm expecting. So I would like to have an intra-arterial BP for beat-to-beat recording of blood pressure and for analysis of the biochemistry. And I'd like to see the central venous pressure, baseline central venous pressure for the fluid status. And I would also preferably use a cardiac output monitor like flow track to use the stroke volume variability for goal-directed fluid therapy. In addition to that, I will monitor the patient's urine output also. Urine output and body temperature. Sir?
Yeah, good. Yeah, that's very good. The present strategy is to have a more of restrictive fluid therapy than liberal because it adversely affects the bowel anastomosis and leads to bowel edema and can lead to it's one major cause of bowel leak in the postoperative period, anastomotic leak.
I will ensure that urine output of 0.5 ml per kg per hour is there, and anything more than that is not really required. 0.5 to 1 ml per kg per hour, and I'll titrate my fluids according to the stroke volume variability or pulse pressure variability. And I will mostly I will use histological crystalloids.
Balance salt solutions also.
Balance all solutions also. Yes, sir. Shall I proceed, sir?
Yeah. So what's your anesthetic technique?
My preferred anesthetic technique would be a general anesthesia supplemented by thoracic epidural analgesia.
Okay, thoracic epidural at what level and why?
Sir, if provided this is a carcinoma head of pancreas, so the surgeon will be planning a Whipple procedure, which will have an upper abdominal rooftop incision. So I would like to place my epidural at the level of T6 to T8 to cover the area from T6 specified process to the lower thoracic and upper lumbar levels. T6 to T8, sir.
Okay. Okay. So what is the choice of inhalation agent and IV agent, muscle relaxants?
Sir, my concern in this case is that an obstructive jaundice patient in front of us. So with regard to inhalational agents, I have to choose an inhalational agent which would preserve the hepatic arterial buffer response, which does not decrease the blood flow to the liver. Preserves the hepatic arterial buffer response. So at a MAC of 1 or less than 1 with a multimodal anesthesia, I would be comfortable with using anything among sevoflurane, desflurane, or isoflurane. I would avoid anesthetic halothane. Regarding intravenous anesthetic, our principles would be to maintain the cardiac output, maintain the arterial blood flow, and maintain normolemia. So my choice in this case would be propofol, because propofol does not affect, even though the cardiac output is affected, clinically there is no adverse effect on the liver, and also it has an antioxidant property. So maintaining adequate hemodynamics, titrated doses of intravenous intravenous anesthetic can be administered, sir. And regarding muscle relaxant, there is a decreased level of pseudocholinesterase. Therefore, the action of scoline can be prolonged, and also the patient is prone for bradyarrhythmias. And regarding the use of, my choice in this case would be cis-atracurium or atracurium, as the elimination is by Hoffman's elimination and not dependent on the liver and renal function. So cis-atracurium or atracurium, according to the availability. And also in case of steroid compounds, if vecuronium or pancuronium are used, it is they will be having a high volume, we will have to use a high loading dose and lower and titrated maintenance doses. And I will give my muscle relaxant strictly according to the neuromuscular monitoring, trainer for monitoring, and titrate my doses accordingly, rather than giving a fixed dose.
Dr. Maria, there was a query, can we use rocuronium?
So neuromuscular monitoring.
Rocuronium can be used. It is a steroidal compound. If the patient advanced liver disease, then he will have an increased volume of distribution. So this will necessitate a higher loading dose. And rocuronium will have an increased duration of action. So you will have to titrate the maintenance doses based on the neuromuscular monitoring. Provided you have a neuromuscular monitor and you titrate the doses accordingly, rocuronium can be used, sir.
Okay, fine. Go ahead.
Coming to the other medications, our goal is to maintain adequate hemodynamics and preserve the hepatic and renal blood flow and prevent end-organ dysfunction, and also prevent the worsening of any hepatorenal syndrome, prevent the occurrence of hepatorenal syndrome. So you achieve this goal with IV fluid therapy and also vasoactive medication. I will have a central for monitoring as well as for administration of vasoactive medication. I would prefer to use noradrenaline 4 mg diluted to 50 ml according to the I would say the baseline blood pressure, and maintain the hemodynamics with the vasoactive medications. And my other concerns, other than the hemodynamics and adequate balanced anesthesia, would be prevention of hypothermia, especially this patient being a geriatric patient and with the invasive, very invasive surgery, is very prone for hypothermia and is at high chance of increased oxygen consumption and delayed shivering towards the end, and also delayed recovery. Therefore, we need to ensure that patient is hypothermia in the patient is prevented with pre-warmed IV fluids, warming blankets, and regulating of the theater temperature, and also the mechanical prophylaxis of mechanical DVT prophylaxis has to be continued through the in the intraoperative period also. That is, he can have the DVTs talking in situ, and the sequential compression device can be connected during the surgery.
Okay, one more thing, probably we need to care regarding the post-operative infections. Hypothermia prevention also helps in that. Plus
Yes,
antimicrobial, pre-operative antimicrobial prophylaxis you need to give. And in an infusion, usually 30 to 60 minutes. And suppose you are depending
1
on
hour of
practice, it includes something like a vancomycin, then you have to give prolonged infusion, longer duration, and probably it may need to be repeated if the total duration of surgery goes beyond maybe 4 to 6 hours, depending on the half-life of the chosen antimicrobial.
Yes.
Can we get an input from Dr. Lakshmi on this antimicrobial prophylaxis?
Intraoperative blood cultures. Sorry,
Sorry, your mic is, yes.
Yeah. So, Whipple surgery, almost every guideline recommends a prophylactic antibiotic, and up to 72 hours of post-operative, up to 72 hours post-operatively, antibiotics are definitely recommended, basically to reduce the chance of post-operative infectious complications. And bile culture is also something which is routinely done. Intraoperative bile cultures are taken, and if it is a stented patient, we almost always get polymicrobial culture positivity, and then we will have to continue antibiotics according to the culture sensitivity reports of the intraoperative bile cultures. So even if it is a completely clean culture negative patient, 72 hours we usually give broad spectrum antibiotics.
For an anesthesiologist, if there is a major blood draw, also we repeat the dose of antibiotics. Or otherwise, if the surgery is more than 4 hours, also we repeat the antibiotics.
Okay, Dr. Maria, because our patient is a diabetic patient also, some of our viewers want to know how you maintain the glycemic control, what's your target, how often you check blood sugar intraoperatively.
We would have checked a fasting blood sugar in this patient. So if it is normal, you do not intervene. And see, we have put in an arterial line. So if the surgery is uneventful, the baseline sugars are normal, we need not check intermittently. Otherwise, as the dissection progresses, and if 4 hours or 4 hours into the surgery, what we practice is to check an arterial blood gas and analyze the glucose in that. Or you can, if not, you can check with the glucometer. So my target would be a range of 110 to 150 milligram per deciliter. I would not aim a blood sugar less than 110 or 80 to 110, because a tight glycemic control is found to have adverse effects on the postoperative outcome. So 110 to 150 would be a favorable target for intraoperative glycemic control, and I would maintain it with intravenous insulin. Intravenous, if the preoperative, if the first value itself is higher, then I would maintain an insulin infusion 20 in 20, and I would titrate. It will require more frequent checking of blood glucose and titrating the insulin infusion accordingly. With strict monitoring of the serum potassium levels. If the potassium levels are lower at the lower limit of normal, along with the insulin, I will be supplementing potassium chloride. I would prefer to use a glucose insulin potassium if required.
That depends on your potassium values.
Potassium values.
Dr. Lakshmi, even postoperatively, diabetes management, like glycemic management, is a challenge after this pancreatic surgery, right?
Yeah, definitely, because the diabetes becomes even more brittle. And if the patient, for example, our patient was preoperatively managed with oral anti-hypoglycemic agents, but almost always post-operatively, we will need to switch over to insulin for a proper control because of pancreatic endocrine insufficiency.
Okay, Dr. Rajesh, you want to give some comments?
As soon as we put an arterial line, we check the blood sugar, electrolyte, so that we know the blood sugar level, and we can control the any electrolyte imbalance also it can be controlled along with the blood sugar.
Plus, we'll get a baseline lactate also.
Baseline lactate also, hydration status also.
Okay, fine. Dr. Maria, we'll proceed.
So this is the arterial blood gas analysis post resection and anastomosis. Intraoperative, after the major part of this invasive surgery is over, we checked we did an ABG analysis, and this was the outcome. pH was found to be 7.42, PCO2 was 40.5 millimeters of mercury, PO2 was 322, bicarbonate was 27, base excess of 4, lactate of 1.1, and glucose of 110 was obtained.
So is there any indication to go for elective post-op mechanical ventilation? Because hemodynamics reasonably controlled and ABG parameters reasonably acceptable levels.
In this patient, no, sir. I would prefer to extubate this patient in a
How
hemodynamic.
about the fluid balance, like how much blood transfusion, how much IV fluid intake output?
Sir, if in case adding to this ABG picture, first we have to see the clinical status of the patient. Like if the surgery was uneventful, if the patient did not have any massive blood transfusion, no massive fluid shifts, and we are not anticipating a dilution coagulopathy, and the patient is there is no hypotension, there is no hypoxia or hypercarbia, and lactate is only 1.1. Lactate is also not elevated, and the pH is normal. There is no acid-base imbalance, and patient glycemic status is also optimal. It is at 110 milligram per deciliter. So in this scenario, if also if the surgeon is comfortable and we are not the surgery part was also not very difficult, and they are not expecting any immediate complications in the immediate post-surgical period, our best choice would be to extubate this patient on table.
So what about the transfusion strategy in this case? This is a patient with a cardiac problem associated with cardiac morbidity. So how is it different from a normal patient?
Sir, in an asymptomatic patient without comorbidities, I can keep the transfusion trigger as low as 7 to 8 gram percentage. Whereas in this patient, being a geriatric, being a patient of more than 70 years and with diabetes, hypertension, and coronary artery disease, I would like to keep a higher transfusion trigger of around 9 to 10. I would like to maintain his hemoglobin above 9.
Very good.
To prevent end organ damage and to maintain, to ensure adequate oxygen delivery to the tissues.
Good. That's acceptable.
Yes, please proceed. Post-operative concerns.
Yes, sir. So now we have extubated the patient, and after extubation, we have ensuring that the hemodynamic parameters are normal, and also the patient is satisfied. The patient is awake and fully oriented and pain-free. And we shift the patient to the post-anesthesia care unit. In the post-anesthesia care unit, our major concerns in management would be first analgesia. So we would use multi-modal analgesia. The primary component would be thoracic epidural analgesia, which has the benefits of decreasing the pain scores and preventing postoperative atelectasis and increasing the respiratory mechanics, and also decreasing the stress response, and also contributes to improved wound healing. Thoracic epidural analgesia titrated to the patient's pain scores along with paracetamol. If the OTP liver enzymes are not high, paracetamol can be supplemented, along with the thoracic epidural analgesia has an opioid sparing effect, but according to the pain score of the patient, you can even administer transdermal opioid, transdermal fentanyl, if the patient pain is not controlled with the above measures. Then I would ensure adequate volume status with good urine output with hydration. Glycemic status has to be checked. Blood sugar has to be checked if normal every 4 hours, or if abnormal accordingly. Then I would like to get after 4 hours post-operative lab values of hemoglobin and electrolytes and renal function to look for any renal dysfunction or any ongoing blood loss. And then I would like to, if the course is uneventful, I would like to mobilize the patient along with the opinion from the surgeon, along with input from the surgeon and the medical gastroenterologist. I would decide on the patient's nutrition regarding if in uneventful, if the course is uneventful, they are usually the feeding jejunostomy is started on the second day, and oral feeds are started in small volumes, 30 ml from the third day. So accordingly, with the multidisciplinary opinion, I will decide on the nutrition of the patient, and I will continue the thromboprophylaxis with mechanical means like DVT stockings and sequential compression device. And anticoagulation pharmacological means has to be restarted only when the hemostasis is adequate. I will prevent hypothermia and antibiotics as per the previous regimen of the patient.
It's important to mobilize the patient
also
as early as
prevent
possible.
bedside prevention. Yes, sir.
It's important to mobilize the patient as early as possible to prevent the deep vein thrombosis.
Especially if uneventful and the patient is comfortable, usually the second day itself, usually the patients are mobilized.
And the nasogastric tubes are removed as early as possible. And the post-op ECG also, you have to check for any changes.
Yes.
Okay, Dr. Lakshmi, your inputs from your side in the post-operative management of post-Whipple's resection?
Whether to give albumin infusions or not is also a common question, especially in patient who is malnourished preoperatively. We don't want anastomosis to be compromised in any way. So many centers would go in for albumin infusions also to maintain a reasonably good serum albumin level. So I think I can get Rajesh's input on that.
Pardon?
Whether you give albumin infusions in the post-operative phase.
Yes, we do according to the serum albumin level, and sometimes to goal-directed fluid removal also we start albumin plus diuretic infusion in the post-operative period.
Yes, especially in patients with this kind of cardiac risk, I think albumin and diuretics may definitely have a role. And if there is a patient is not tolerating albumin, the usual 20% albumin, we can go in for at least 5% albumin, 5%, which may be better tolerated by an elderly cardiac patient.
And to add, Dr. Maria, she said she emphasized the importance of thoracic epidural also. But most of the time, it's a matter of multimodal analgesia. The paracetamol up to 2 grams per day can be given as per the gastro view. But most of the centers doesn't give a routine paracetamol infusion. NSAIDs is definitely it's not indicated, or it's contraindicated. And opioids also. Even the basic science and literature says the adverse effect of opioids and immunosuppressive roles, but the large multicenter studies is contrary to the belief. And in fact, Dr. Maria can share at the end, there is a large population-based study, which is around 34,800, 35,000 patients. But that's on breast cancer, and they found that no association between opioid use and cancer recurrence. So they do not advocate a change in practice, but definitely restricting the use of opioids is sparing effect has got a role in the early mobilization and improving the pulmonary function. Cardiac profile also, right?
I think we are side by side answering the query in the chat box also. If you have got any more queries, comments, you can put in the chat box. We'll address it definitely in the last Q&A session as well. So, right, next slide, please. Next slide. Yeah. One question for audience. Significant postoperative anemia after pancreatic resection is expected due to intraoperative blood loss and can often be managed with blood transfusion alone. Is it true or false? So that's the question. Is blood transfusion the only answer or the predominant answer for a postoperative drop in SP? Yeah, I understand that most of our energetic residents are texting their questions in our chat box, and we are taking down the questions and trying to answer all these things. So now it's your turn to answer our question. Okay, I'm stopping the poll in another 5 seconds. I think there is some disparity between two sections of our participants. Almost 50% believe it's true, 50% it's false. That's how the response is. 47 believes it's true, 53 believes it's false, and I am with that 53. The answer is false, because post-pancreatectomy hemorrhage, there are many reasons. Could be due to pseudoaneurysm or anastomotic leaks. There are different non-operative measures also other than blood transfusion. Interventional radiology procedures should be used when bleeding is due to pseudoaneurysm, while endoscopic procedures advocated when the source is anastomotic. So the options are there. Definitely you need to think in a multidisciplinary way. So it's not only about filling the tank, you need to seal it also. You need to find what exactly is the cause for a sudden drop in hemoglobin in the post-operative period. It may not be always due to intraoperative blood loss. Okay, we can proceed.
And pancreatic fistula, development of pancreatic fistula is one common post-operative problem, complication.
Yeah. So we need to discuss regarding the use of nasogastric tubes, drains in the post-operative period. So we'll start with Dr. Lakshmi for major post-operative issues after the Whipples.
Obviously, from a surgeon's perspective, they would be concerned about the leaks and bleeds. So, which is the most common thing. Almost always they are managed conservatively, and majority of the leaks would settle on their own. You just need to give it time, prevent superadded secondary infections, and ensure that the drain is in situ. If there is a leak, if you have the drain in situ, it acts as a lifeline. So, drain removal is always a tricky question. The fluid amylase levels are often used as a guideline to decide on drain removal. Obviously, fluid amylase level as well as the volume of drain. These are two important decisions, aspects on which we decide whether to remove the drain or not. So, if there are many criteria based on the day one fluid amylase levels, but so many practical issues can happen. Minor kinks or blocks in the drain can be there. So, just going behind a single criteria of post-operative day one amylase levels may not be sufficient. It has to be taken in the context of the clinical setting of the patient. If there was a difficult surgery, the pancreas was very soft, the anastomosis was difficult, patient was obese, and all those kind of things, then you would rather keep the drain for a slightly longer duration. There are many studies trying to see whether you can remove the drains early, but for most surgeons, those are limited to study settings, and drain is kept till they are sure that there is no leak. And drain removal usually by day 3 to day 5, if there is no leak, usually most surgeons would prefer day 5 at least for removal of the drain. Now, if there are leaks, the major question that comes, as I said, management is conservative. You need to wait, and in that waiting period, the nutrition is the most important. So if there is a feeding jejunostomy in situ, it is always very helpful, because while the patient's leak is getting settled with conservative management, feeding jejunostomy will take care of the nutrition, and we can ensure adequate calorie and protein intake through the feeding jejunostomy. Now, long-term postoperative complications like pancreatic, endocrine, and exocrine insufficiency, even malnutrition because of exocrine insufficiency are very common. So we need to address the nutrition status of the patient and diabetes also very closely in the long-term postoperative period.
Okay, and there was a query on the role of TPN in the postoperative period.
There are many studies on TPN in the postoperative period. In fact, there are studies which show that it is, see, why you start enteral feeds just after a Whipple. It's not that you go into full enteral feeds immediately. You cannot do that. There are studies, people who start enteral feeds by 12 hours also, but that is just to promote the gut motility, prevent postoperative ileus and all that. Full nutrition will not be possible for quite a few days after Whipples. So that is why studies have shown that TPN definitely has got a significant role, especially in the early postoperative phase. Until the patient starts taking a reasonably acceptable diet, we may have to go in for TPN if the patient is nutritionally very poor pre-operative and you have not got time for optimization. Many times I have that 2-3 weeks time for optimization. So in that patient, there may be a role in the 5 days till you are able to ensure a good enteral nutrition. They have to go in for TPN.
Okay, fine. Dr. Maria will give the remaining details in the postoperative phase of this case.
So this patient on the first postoperative day had a hemoglobin of 9.9 gram per deciliter. Sodium was 137 millicoulomb and potassium 4.3 millicoulomb per deciliter. Serum albumin was found to be low. It was 1.8 gram per deciliter. And in this case, so this patient, sorry about that, this patient received a albumin infusion. 20% albumin infusion was given for this patient. The feeding genitourostomy was used from the second post-operative day, and he was mobilized on the second day. And oral feeds were started on the third day. They have a 30, 60, 90 ml policy of giving the oral feeds very slowly in small volumes. They are started. And otherwise, the postoperative course was uneventful, and the patient was discharged on the 10th postoperative day. Regarding the epidural catheter, after shifting from the PACU, the patient was on epidural infusion for 2 days, since we are expecting maximum postoperative pain during the initial 3 to 4 days. So somebody had a query on the adjusting the dose, adjusting the low molecular weight heparin and the epidural. So if the patient was already put on prophylactic Clexane, it has to be stopped 12 hours prior to the surgery. And after the hemostasis is achieved with the epidural catheter in situ, it can be restarted. And if the epidural drug infusion is over, and if if the pain scores are less, and we are planning on removal of epidural, you have to stop the Clexane, hold it for 4 hours. You have to time the Clexane accordingly so that he does not miss it. And after 4 hours of the last dose of Clexane, you can remove the epidural. And after the removal of epidural, 1 hour after the removal, we can actually restart Clexane. If there is no, Clexane can be restarted. So that is the, and ideally the patient after discharge also, the patient needs pharmacological, patient needs to be actively mobilized, and also a pharmacological DVT prophylaxis also has to be continued in the post-operative period even after discharge, because we have seen a very high incidence, relatively high incidence of DVT and pulmonary embolism causing major mortality in patients undergoing Whipple surgery.
Okay, fine. Next slide, please. Yeah, this is for our audience. This is true-false question. This is very important. This is probably one of the take-home messages. Thromboprophylaxis should be considered until the patient is ambulatory and stopped prior to discharge. True, false? Would you agree with that or disagree with that? Thromboprophylaxis until the patient is ambulatory and stopped prior to discharge. Yeah, fine. I'm seeing a neck to neck opinion clash, almost 50% agreeing, almost 50% disagreeing. So yeah, I'm stopping the poll. Actually, this is exactly the point Dr. Maria was explaining just before this poll. Because this condition per se is a very high risk factor for DVT, and the prophylaxis should continue even after discharge for some time. So that's the message. You cannot just stop thromboprophylaxis just because patient is ambulatory, and you cannot stop at that point of discharge. So patient should be discharged on a thromboprophylaxis measure. Next. So I hope that message is clear. So you don't take risk. Dr. Maria, just advance.
Yes, sir. I have a clarification. I just remembered a clarification on the heparin in the catheter removal. If it is unfractionated heparin, it is as 4 and 1. If it is a low molecular weight heparin, we are giving, we have to hold it for 12 hours before catheter removal, and you can restart Clexane 4 hours later. It is fractionated and low molecular weight because of longer action.
So you have to look into the which low molecular heparin they are using. Most of the low molecular heparins has got an half-life of 6 to 12 hours. So you can wait for double the half-life. So
yes.
Okay, we are almost coming to the conclusion of this grand rounds. So we have been speaking about an integrated perioperative management. So we need to take care of preoperative, intraoperative, and postoperative strategies. Dr. Maria, next slide, please. So preoperative strategies, summing up, we should get an informed patient consent. Preoperative risk assessment is important. We need to evaluate and optimize the preoperative physical conditions and medications. Nutrition status is a major point in the optimization part. Risk stratification, rationale for thromboprophylaxis, and recommendations we have discussed. Coming to intraoperative. Next slide, please. Yeah. Usual technique of anesthesia is combined general anesthesia and thoracic epidural analgesia. Prevention of surgical site infection, especially with antimicrobial prophylaxis. Avoiding hypothermia is important. Glycemic control we have discussed. Blood transfusion management. Intraoperative fluid management. Optimization of intraoperative ventilation. Intraoperative thromboprophylaxis. Yes, in the postoperative period. Early nasogastric tube, catheter, and drain removal is the strategy these days. Early oral nutrition, glycemic control, goal-directed fluid therapy. We have discussed the role of albumin and even fluid removal in the postoperative period. Analgesia, pain relief, predominantly multimodal, based on non-opioid oral analgesia may be supplemented. Intensive postoperative ambulation and prevention of venous thromboembolism. Intensive respiratory rehabilitation, intensive postoperative management. Yes, you need to ship the patient out of the post-anesthesia care unit to the ward, but continue the rehabilitation, continue thromboprophylaxis even after the discharge. Before concluding, one more question for the audience to respond. This is again multiple response question. You can choose whichever options you find true. Option A will be once pancreatic cancer is suspected for the initial imaging studies, next step in the workup is generally a staging evaluation to establish the disease extent and resectability rather than biopsy. Option B, endoscopic ultrasound guided FNA is the best modality for obtaining a tissue diagnosis, even if the tumor is poorly visualized by other imaging modalities. Option C, degree of elevation of CA19-9 is associated with long-term prognosis. Option D, complete surgical resection is the only potential curative modality of treatment of CA pancreas. So here you have the poll window in front of you. So we'll be proceeding to the Q&A session after this. Yes, I know the options are slightly lengthy, but at the conclusion of this grand rounds, I think this should be reasonably okay statements. Yeah, I'll wind up the poll in another 5 seconds. Yeah. So can you put the previous slide, please, Maria?
Once again, sir.
Yeah. Option A, 90% agree that it is true. Yes, it is true, because once pancreatic CA is suspected on initial imaging, next step in the workup is generally staging, a staging evaluation to establish the disease extent and resectability. Tissue diagnosis may not be possible in most of the circumstances. Yes, that is a true statement. Option B, 69% believe that is true. That is a correct statement. Endoscopic ultrasound guided FNA is the best modality for obtaining a tissue diagnosis, even if the tumor is poorly visualized by other imaging modalities. How about option C? Degree of elevation of CA 19.9 is associated with the long-term prognosis. 66% says it is true. Yes, it is a true statement. Option D, complete surgical resection is the only potentially curative modality of treatment of CA pancreas. 59% says it is true. It is true. Actually, all the false statements are true, because I thought this will be something like a summary slide, or take home points are there. Surgical resection is the only potentially curative modality, because after the diagnosis, 5-year survival is very less if the patient is inoperable. So surgery will take the good prognosis slightly up, but still it's a difficult number when you get to see the 5-year survival rate after a diagnosis of CA pancreas. Okay, next slide, please. So, Dr. Lakshmi, your concluding remarks. Suppose you get that our case was relatively early detected, as you mentioned, and how about the other patients who are diagnosed with inoperable malignancy?
For a patient with inoperable malignancy, this patient who has jaundice, we palliate the jaundice using metallic biliary stents. So in that case, there is no doubt we definitely need to go in for ERCP, put in a stent and put a metal stent. And palliative chemotherapy also does have some role, especially in the survival. And pain palliation is the most important thing in these patients. I think you'll be discussing on pain palliation with opioids. From our side, we do endoscopic ultrasound guided celiac plexus block for pain palliation. So in the long term, if it is inoperable, prognosis is extremely poor. Stent palliation is what we do.
Okay, Dr. Rajesh, your comments?
This patients with advanced CA pancreas is common in the pain clinic setup. So you have interventional options as well as pharmacological options. Pharmacological options, of course, is most of the time you may require step 3 analgesics. That means the opioids, oral opioids. And regarding oral opioids, you should be very careful because the patient have the prolonged effect of opioids because of liver metabolism and poor elimination. So you have to teach the caregivers that if the patient is drowsy or the patient is not responding, you have to skip one dose or reduce next dose. So usually morphine is available in 10 and 20 milligram preparations. Usually it is 10 milligram preparations. So regarding the interventions, you have option of celiac plexus block. Dr. Lakshmi has described the celiac plexus block, but we give under CM guidance in the prone position. And you should warn the patients about possible diarrhea and hypotension. You should have a secure IV line before doing celiac plexus block. It gives pain relief for at least 6 months if it is you have reached the plexus properly with absolute alcohol. At least you may not be able to completely take out the opioids, but you may at least reduce the dose of opioids with an effective celiac plexus block.
Okay, fine. Dr. Maria, next slide. We'll take some questions because there were lots of questions, but fortunately, most of the questions were answered through our grand rounds. One clarification, this NSQAP score, somebody mentioned whether it is applicable in Indian scenario because that database is not an Indian one. Yes, there was a literature saying that it's not actually validated for our Indian population. The idea of introducing it in this forum is to introduce the culture of giving more objective values regarding the postoperative complications and basically discussing what to expect when the patient comes to the theater, when the patient goes to the postoperative, and when possibly the patient can be shifted out of the post-anesthesia care unit. So this explanation will make the informed consent more valid, and will get more cooperation from the patient and their relatives if we are actually trying to give objective numbers regarding what to expect, rather than your case is very high risk and even death on table is possible. That will actually create a gap, bigger gap between the treating team and the family. So that is one thing. POSM and PPOSM scores, yes, that can be used for risk prediction for mortality, morbidity, for major surgeries. That is one thing. Other thing is question to Dr. Lakshmi regarding when to choose metallic and plastic stents and pros and cons. Dr. Lakshmi, am I audible? I think that there is some internet connectivity issue. Sorry, the voice is breaking. Okay, we'll get that input when the connection is better. And Dr. Rajesh, can you clarify regarding the goal-directed therapy and how much fluid to give?
The basic principle of fluid management is you have to restrict the fluid and not to overload the patient, because we are aware of the increased fluid given to the patient. It can cause anastomotic leak, and in addition to adverse cardiac and pulmonary problems. So you can go for restrictive fluid therapy. And Dr. Maria has described the various parameters on which we monitor the fluid requirement, like stroke volume and CVP also. But CVP cannot be taken in isolation. It has to be interpreted with other hemodynamic variables also.
Okay, fine. I think we'll go back to Dr. Lakshmi regarding the type of stent, pros and cons.
Yeah, classically, plastic stenting was done in pre-operative, and if there is a palliative case, we used to do metallic stenting. But nowadays, many guidelines are advising for metallic stenting pre-operatively, mainly because the infectious complications are much less, but cost factor is very high. So in Indian setting, we still go in for plastic stents pre-operatively and metallic in palliative cases. And PTBD, there was a question whether PTBD can be done. PTBD is done for lower and biliary obstruction only if the we have some problem, we have difficulty in doing ERCP, then only PTBD is indicated. First choice is ERCP only.
Okay. Okay, thank you. There was a query on postoperative hepatorenal syndrome. How do we manage?
Yes, hepatorenal also, I think it's mostly prevention. What we have to understand is Whipple's by day 2, the patient has got a normal liver function. Once anastomosis is functioning well, the liver function normalizes. So mostly prevention, intraoperative hemodynamics, maintaining the volume status correctly in intraoperative phase, we can prevent hepatorenal syndrome. And if albumin infusion again has got a role in prevention of hepatorenal. Usually, if it is prevented, we don't have to deal with it in the post-operative phase.
Okay, I think there are a few more questions remaining, but we are running short of time, and probably we'll take those questions in the subsequent grand rounds in the again on surgical gastroenterology case. Any closing remarks from Dr. Lakshmi and Dr. Rajesh? Welcome.
What I would like to say is that it is a multidisciplinary management because many from the medical gastroenterology, surgical gastroenterology, even interventional radiology. In case of a complication, we go in for interventional radiology, anesthesiology. So it is pancreatobiliary malignancy management is definitely a multidisciplinary approach, and only if you have a good teamwork, the success rates are good.
Okay. Dr. Rajesh?
It's a major intra-abdominal procedure, and of course, a good teamwork is a must. Prior communication with the surgeon. What is the extent of disease? What is the extent of blood loss they are anticipating? If there are any lymph node involvement, or if there is a pre-existing cholangitis, and if the stenting has done pre-operatively, all these things has to be communicated with the surgeon. And as emphasized in throughout the discussion, the consent has to be taken at every step in the anesthesia, like including thoracic epidural, its pros and cons, the lines you put in the induction phase, and the expected outcome in the postoperative period, like whether you are anticipating any cardiac morbidity or post-operative ventilation. Everything has to be explained to the patient beforehand, because any mishaps can happen during the intraoperative period on the postoperative period, because it's a major procedure with the major vascular shift. And one more point to add, Dr. Lakshmi, Madam has said that to prevent hepatorenal syndrome, the perioperatively, previously we used to give mannitol, but that concept is now outdated, and now we maintain normovolemia. I think Dr. Maria has emphasized in their presentation also that point.
Okay, fine. Dr. Maria, thank you very much for taking extra efforts to present in this grand rounds. I appreciate your efforts and presentation. I thank Dr. Rajesh to suggest this topic and take initiative to bring it this further. And I'm happy that my own batchmate, Dr. Lakshmi, has joined with her inputs and expertise, because we usually think about Dr. Lakshmi as an academic excellent person, right from school days to until this. So thank you very much for joining. We always appreciate input from our co-speciality consultants. It's been nice to have your inputs.
Thank you, Dr. Sanish, for the invitation and your idea to have a multidisciplinary approach, because that's very important, because we may not all the time, we may not have the inputs from the other specialties. We only speak ourselves. Like we may not have a cardiologist or pulmonologist in the forum, and this is Dr. Sanish's idea. So, and I also congratulate Dr. Maria. She has presented it very well. She's a very good student with a good academic background, and she has presented it in a very short notice. In fact, she was at home and she got only 3 or 4 days to prepare. And I actually thank Dr. Lakshmi, because we have discussed the case with Dr. Lakshmi, and a lot of her inputs also helped. Thank you, Dr. Sanish, once again for the invitation. Thank you. On behalf of BMH also. Thank you.